us. I'm just going to move quickly through some of these cases. So this is a 21-month-old with a pyrexia of unknown origin and a rapid clinical deterioration. So this is the unenhanced CT head, and it shows quite a nice finding that I find quite useful when trying to assess the ventricles in young children in particular, which is that you can just see this biconvex appearance of the third ventricle here. It just kind of looks a bit too fat. And if you're particularly on the ball, you might also pick up this focal area of low attenuation in the left thalamus there. So it doesn't look quite right. Potentially there's a sort of intracranial infection going on from the clinical history. So the patient goes on to have an MRI to see what's going on. So on the top left-hand corner, you can see axial T2 weighted imaging with focal high signal intensity in the left thalamus, where we saw on the CT, spotty T2 hyperintensities that when we look on the axial DWI and ADC map, show diffusion restriction. So these, diffusion restriction is probably an infarct, and in the context of sepsis, these are perforator territory infarcts due to all of the kind of pus and infection that's around the base of the brain surrounding these perforating vessels. The other thing to look at on this case is just very carefully compare the symmetry of the extraaxial space. You can see on the right-hand side there's this thin T2 hyperintense enlargement over the right lateral temporal convexity. But importantly, when you look on the ADC map, it's also still hyperintense. So you can often see these reactive subdural effusions in intracranial infection. It doesn't mean automatically that they are subdural empyema, although obviously that's one of the complications that you might expect. On the post-contrast imaging, you can see this avid caking enhancement around the basal cisterns. Now, when you do a paediatric MRI of the brain under GA, you often see quite kind of avid enhancement of the vessels over the brain, even in normal children, and it can be quite difficult to decide for definite whether there's abnormal leptomeningeal enhancement there. But two tips I always use are, if it actually circumferentially coats the brain stem, that's abnormal. And if you can spot an abnormally enhancing cranial nerve, be it the third nerve or the fifth nerve or maybe the seventh nerve in the CP angle, those are convincing, definite, abnormal foci of leptomeningeal enhancement. So in the end, the diagnosis here was pneumococcal meningitis. Oops. The next thing I wanted to show you on this case is how useful diffusion-weighted imaging can be in addition to infarction, but to show you complications. So here you've got a layer of diffusion-restricting material in the left occipital horn. It doesn't really enhance very much, but there is definite diffusion restriction on the ADC map. So this is ventriculitis or pus in the ventricles. A bit like the subdural collections, these don't have to restrict, so you can have turbid material that just kind of settles out in the occipital horns without restriction. It's a very aggressive disease, particularly pneumococcal meningitis, and you can see this is the follow-up scan where there's been progressive, despite treatment, ischemic damage. The pattern is perforator ischemia, so lots and lots of basal ganglia changes, thalamic changes. You can see all of these ischemic lesions in the midbrain, worsening appearances of the ventricles. But also, looking at the parasagittal convexities, you can see there's these linear parasagittal foci of diffusion restriction that don't really, they kind of look a bit like MCA infarcts, they're sparing the midline. And when you go on to look at the MR angiogram, you can see the effects of what effectively is an infective vasculitis contributing to all of these appearances. So there's stenoses in the proximal MCAs, and when you rotate it round and look at the supraclinoid ICAs, there's tight stenoses there. This is a companion case just to show you that it's not always that obvious. This is a 14-year-old girl who had a clinical presentation of meningitis following influenza. And it just illustrates another tip in looking for intracranial infection. She's got this kind of subdural collection over the right frontal convexity. Again, it's not restricting, so this is just one of these reactive subdural effusions. But if you look at the axial flare imaging up here, you can see that in the sulci over the convexities bilaterally, normally you would expect the CSF to invert and that to be low signal there, but it's high signal. So this is abnormal CSF signal. Again, post-contrast doesn't really help you that much. This was a partially treated case. So the flare is really useful at picking up regions of abnormal CSF. It's fairly non-specific, so it can be any kind of protein or blood or other things going on that can give you that high signal. But obviously in the context of infection, you're going to raise that as a possible abnormality. Mary showed us a nice case. This is a similar one. This happens fairly frequently in children. This is a 16-year-old boy with a history of a cold that went on and on and on, and then worsening frontal headache. You can see the parafalcine subdural collection with a pocket of gas at the front of it. They don't always have pockets of gas in, so it's not as easy as that usually. So this is going to direct your search down to the frontal sinuses, which you can see are pacified with a small pocket of gas there. Potential complications from this, the infection can spread both ways. It can go forward into the subcutaneous tissues over the frontal bone, and they might present with a mass, the Pott's puffy tumour, or it can spread intracranially, as we've seen here. This is the MR to kind of show you how it looks in detail. Parafalcine collection, avid diffusion restriction, but also all of this abnormal high signal in the T2 and the cortex and the adjacent brain with diffusion restriction as well. So this is focal cerebritis secondary to the infected collection. When you go down further, you can see where this is all coming from. Don't forget you often include the maxillae on your lower imaging slices of the brain, and these show avid diffusion restriction in the maxillary sinuses, consistent with sort of mucopus, as it were. This is another infection coming from outside the head in children, fairly common. The reason I wanted to show it to you is because there's a sort of distinction to be made based on the imaging appearances. So this is a 21-month-old with a 1-week history of pyrexia and a swelling over the right mastoid process. You can see this is an unenhanced scan. You can see there's a subgaleal low-density collection. There's something going on here by the sigmoid sinus. It's low density. And then as you look further up on the brain windows, there's some high density in the sigmoid groove there. You can see that the mastoid air cells are diffusely opacified on the bone windows. When we look on the MR, you can see this is a really T2 hyper-intense collection inside the head. It's sort of extending outside the sigmoid groove, and that's important because although it's definitely showing you diffusion restriction consistent with an abscess or a infected collection, sometimes thrombus in that location can give you abnormal diffusion signal as well, can cause some diffusion restriction depending on the stage of it. So the way to sort that out is to try and follow the anatomy a bit more closely. So here's the infection, all centered around the mastoid air cells with the extracranial component, the intracranial component. This is actually outside the dura, so between the bone and the dura, so it's extradural empyema, as it were. But further up, in the area where we saw the high density on the CT, you can see this sausage-like low-signal filling defect in the right sagittal sigmoid sinus, consistent with the secondary thrombosis from this infection. And obviously, unsurprisingly, there's absent flow on the MRV. This is a difficult case if you don't do diffusion-weighted imaging, although I'm sure everyone does nowadays. This is a 2-week-old with seizures. Seizures is how almost all paediatric neuroradiology presents, so it doesn't really help you very much without any further information. So, I mean, it's incredibly difficult to see anything going on these axial T2 weighted images. The child's only 2 weeks old, the brain is very wet, there's no myelination to help you. But when you add in the diffusion-weighted imaging, it's really abnormal. You can see these areas of diffusion restriction in the temporal lobe, in the posterior cingulum, but also all the way over the kind of convexities here. Bit difficult to know what's going on. It's asymmetric. There isn't really any kind of cardiovascular instability to help you to say infarction or ischemia. What this is herpes simplex encephalitis, and the type 2 herpes simplex that infants and neonates gets has a different distribution to the usual pattern that we see in older children and adults involving the temporal lobes. It does involve the temporal lobes commonly, but it also involves all of these other areas, particularly watershed areas in the cerebral cortex, and the cerebellum, in fact, is involved in about half of cases. And if you don't raise it, and if the clinicians aren't thinking of it, the patient doesn't get treated particularly for it. And even with treatment, I'll just show you this one as well, it doesn't enhance fantastically herpes simplex. There's possibly a bit of increased cortical leptomeningeal enhancement around there, but the actual brain parenchyma doesn't tend to enhance unless it's broken down or become hemorrhagic. But I just wanted to show you just how destructive, even with appropriate treatment, herpes simplex encephalitis can be, and that if you don't raise it and get the treatment started early, then even further damage can ensue. Talking of seizures, given how common they are as a reason for doing imaging of the head in children, I just thought I'd show you a couple of cases that just show you signal changes that are caused by seizures. So this is a 12-year-old girl with uncontrolled seizures, and these have been going on for quite a long time, so she ends up kind of in MR maybe about 2 days later eventually. And if you just look at the back end of the hippocampus on the T2 on the flare, and also the diffusion-weighted imaging, there's high signal here with low signal on the ADC. So there's bilateral hippocampal diffusion restriction. And this is a reactive change secondary to sort of hyperexcitability within the cells in the hippocampus, and is reversible without the type of gliosis or volume loss you might expect with ischemia. It tends to be kind of fairly isolated to the temporal lobe structures. This is a different case, a 7-month-old with a prolonged focal seizure. And in this case, you just see the kind of diffusion restriction around the anterior part of the hippocampus here, where the kind of majority of the grey matter is. And like I say, it kind of resolves without the damage that you might expect for an infarction, and tends to be localized to the temporal lobes or the hippocampi. In really extreme cases, it is reported that you can see it in other areas of the brain, so in the sort of lobes and with the basal ganglia as well. But the one case I've seen like that effectively managed to break his own arm with the kind of uncontrolled seizures. So it's pretty extreme for you to kind of raise that as the most likely cause. It's a bit of a diagnosis of exclusion if it's outside of those areas. Here's some hippocampal diffusion restriction that's not isolated to the hippocampi. This is a 5-month-old who had an unexplained out-of-hospital cardiac arrest. And you can see that, yes, there is hippocampal diffusion restriction, but already, particularly on the ADC map, you're seeing this more diffuse parenchymal diffusion restriction posteriorly. There are spotty areas in the basal ganglia, and also this kind of, with the eye of faith, watershed distribution in the superior convexities, which brings me on to talking a little bit about technique. This is the same child, 5 months old, and on the left-hand side is an axial T2 image with an echo time of 120, and this is our preferred echo time for children under the age of 1, really, who haven't really got a decent amount of myelination yet, and that's to increase the TE up to 160. And it really kind of helps, I think, to show you areas of abnormal T2 hyperintensity on a background of a brain that's already quite wet and bright on standard T2 weighted images. So I'd encourage you to try that to kind of help to pick out pathology on the background of this wet brain. I think, a bit like Mary was saying, unless you know what you're looking for, it's very easy to miss hypoxic ischemic injury, and they follow these patterns. So if you know the pattern that you're looking for, although it doesn't always correlate very well with the history you're given, then you're more likely to pick up these sometimes subtle abnormalities. These are 2 very good reviews that have been in radiographics in the last 5 or 6 years, really, so I direct you to those to read about them, if you don't already know. So basically, it's kind of split into mild and severe, or mild to moderate and severe, and how long the insult has lasted for. So you can have short and long, mild and bad. So we'll just start through. This is a 2-week-old with bronchiolitis and prolonged desaturations. And what you can see, subtle on the axial T2 weighted imaging, there's a bit of missing cortex here, but pretty hard to miss on the diffusion weighted imaging, is this kind of watershed cortical area of diffusion restriction. There are a few other kind of spotty bits around, but this is a partial hypoxic ischemic injury secondary to the hypoxia from the bronchiolitis. This is a fairly common pattern, probably doesn't project fantastically. The T2 is very difficult to kind of pick up anything abnormal on. But if you look on the posterior putamina bilaterally, you can see there's diffusion restriction there. And the other thing that isn't very widely reported is just how much the cerebellum can be involved in hypoxic ischemic injury. So you want to be comparing the normal signal of the temporal lobe cortex to the diffusion signal change in the cerebellar cortex to see that it is really quite dramatically different. Very easy to miss on the T2 weighted imaging, I think. So this is a short but profound hypoxic ischemic injury. Another short and profound one, this is axial T2 and flare. I think it'd be pretty easy unless you kind of had the correct history to go straight past the findings. But when you look on the diffusion-weighted imaging, you can see this is really obvious deep grey matter, hypoxic ischemic injury involving striatum and thalamus bilaterally. Also, I don't know if you can see, there's just a little kind of few pockets at the base of the sulci as well. And that seems to be an area that is particularly susceptible to hypoxic ischemic injury. This is another one, a bit more global this time, back to CT. This is a child with epilepsy who had a prolonged seizure in the community followed by a cardiac arrest. Reported downtime was about 40 minutes. So this is the CT on admission to hospital. You know, it's difficult. It's a bit grainy. You know, you can still see some grey and white differentiation. You can still see some ventricles. You can, you know, the prepontine system's okay. It doesn't look too bad. 48 hours later, that's what the picture looks like. So complete loss of sulci, lots of swelling, reversal, where you have low density in the cortex and relatively higher density in the subcortical white matter, and complete loss of the basal systems with this white cerebellum sign. So this is just a reminder that if the first scan is abnormal with any age hypoxic ischemic injury, particularly on CT, then consider repeating it if the clinical situation doesn't fit. In children, we tend to do a lot more MR in cases that you might consider hopeless on CT, and they're just as hopeless on MR, unfortunately. But clinicians are much more keen to kind of have formal documentation of just how hopeless things are. This is a really awful hypoxic ischemic injury that happened in the community. Again, unexplained cardiac arrest. There's a shunt in situ from a previous kind of neurosurgical problem. And there really is kind of diffusely abnormal signal in the cortex, compression of the ventricles. The reason I wanted to show it to you is this, which is this kind of odd appearance on the diffusion-weighted imaging. And this is a DWI reversal sign. So normally you would expect the white matter to be of higher signal on the ADC map and the grey matter to be low signal. And this is reversed. And the idea is that this somehow represents some kind of delayed post-hypoxic ischemic damage to the white matter that happens secondary to the cortical insult, particularly if you scan 48 hours or longer afterwards. I should say, when it says older children, that was 18 months. So it's not, I suppose, compared to term and preterm infants. This is the susceptibility-weighted imaging in this case, and if you're not used to it, it can look very odd. You do normally see an increased conspicuity of the veins on susceptibility-weighted imaging. These are really grossly kind of pronounced, and what this is all of the deoxyhemoglobin sort of pooling in the veins within the brain, secondary to the hypoxic ischemic injury. I'm a big fan of SWI in lots of different pathological conditions. I think it really adds sensitivity. And if you're not used to it or haven't started using it yet, this is a really great review that I would direct you to. It's got a nice kind of range of pathologies and explanations from the group in Johns Hopkins. One of the main places I use SWI is trauma. It's really sensitive at picking up extra kind of parenchymal damage and injury. This is a 14-year-old girl who was unrestrained passenger in the back of a car following a car accident. You can see the amount of damage that's already been done to the skull on the CT, subcortical hemorrhages. But what I wanted to show you is this blood in the interpeduncular fossa. And although that could just be dependent blood secondary to some traumatic subarachnoid hemorrhage, in a patient with a reduced GCS, you should consider that there's been a focal brainstem injury here and that this is a marker of diffuse axonal injury. So went on to have MR, and as you can see, there are a mixture of findings. So the diffusion signal is restricted in the corpus callosum, a very typical distribution for diffuse axonal injury. It's not all hemorrhagic. There's possibly a little bit of hemorrhage in the posterior part on the susceptibility-weighted imaging. But the SWI picks up extra parenchymal injuries. You often see these kind of shearing subcortical hemorrhagic lesions at the grey-white matter junction, in addition to all of the more obvious parenchymal contusions and swelling. It wouldn't be a paediatric neuroimaging talk without some non-accidental injury, unfortunately. So just a quick reminder that the diffusely abnormal scan can be an easy one to trip up on. This is a 2-month-old who apparently had a cardiac arrest while feeding. Obviously on the CT, the brain looks a bit kind of featureless, difficult to see grey-white matter differentiation, but can sometimes look a bit like that anyway. There's definitely some abnormal hyperdensity posteriorly. The T2, again, not really right, but if you're not used to looking at it, can trick you. Diffusion's nothing obvious really kind of standing out until you look in the posterior fossa. And this is what the normal signal should look like, and it's actually that the whole supratentorial brain is abnormal. So if you can, try and find somewhere that you think looks normal to compare everything else to avoid missing these diffuse abnormalities. I said that we'd talk a bit about investigating spontaneous intracranial hemorrhage, because in children, this isn't going to be due to hypertension, it's going to be due to an underlying cause most of the time. And I just wanted to show you a tip for CT angiography. This is a 14-year-old who fell down some stairs and then became aggressive, dropped his GCS, but before he dropped his GCS was complaining of some left-sided numbness. So obviously there's a big hematoma in the parietal lobe, subcortical white matter. It's not really a typical location for a traumatic injury, and obviously because it's a child and it's very likely to have an underlying cause outside of trauma, we went on to CT angiography. This is the raw data from the scanner at 0.625 millimeters, which is how we acquire our CT angiography. And it's very easy to miss high density within the hematoma on that, unless you actually do a MIP. So I think these are really helpful to kind of make abnormal vessels stand out. So this is just a 1 millimeter thick MIP from the CT angiogram that shows this abnormal vessel crossing the hematoma, which was confirmed as a micro AVM on follow-up catheter angiography. This is another one, just to talk a bit about MR, using MR. Obviously, we try not to use CT over and over again for looking at intracranial hemorrhage or possible causes in children, if possible. This is a child with a temporal lobe hematoma this time, and we've just been lucky. We've managed to scan him early, so we've got low signal on the T2, but still pretty low signal on the T1, or ISO intense signal. So this is blood in its deoxyhemoglobin state before you get this T1 hyperintensity. And the reason that's useful is most of us use time of flight imaging for the angiography. And if this was full of blood, there's T1 shine through on time of flight imaging, and that would obscure these abnormal vessels and also the contrast enhanced imaging. But what this actually shows is a AVM with a little pseudoaneurysm deep next to the hematoma, which we would have missed had we performed the scan any later. Again, talking about blood and its evolution of signal, this is a child who is on prednisolone for ulcerative colitis, came in with a chickenpox rash, and then started complaining of ataxia and diplopia. There's a T2 hypointense lesion in the dorsal left midbrain, T1 hypointense, but again, the susceptibility weighted imaging helps you out here. This is hemorrhage, and this is hemorrhage in its deoxyhemoglobin state. The reason I wanted to show you this, if you start using susceptibility weighted imaging, but also to kind of slightly dispel a myth about gradient echo imaging, is that this is a week later. So already small hematomas can really quite rapidly go through those phases of evolution. It's already T2 hyperintense, T1 hyperintense, but also look at the susceptibility weighted imaging. Late subacute methemoglobin does not give you very much low signal on susceptibility or gradient echo imaging. There's a little bit of early hemosiderin around the edge of this, but if you'd done this without the previous one, you might be tempted to say, oh, because it's not dark on the SWI, it's not going to be hemorrhage. But this is a phase that the late subacute methemoglobin goes through without much susceptibility effects. This is another difficult case without careful review of the imaging. Another toddler with seizures. You've got these abnormal areas of signal intensity in the centrum semiovale with spotty low signal on the gradient echo imaging this time. Not really sure what's going on, so you have a look up and you can see on the T2 this hyper-intense signal in the superior sagittal sinus, which helpfully stands out like a light bulb on the DWI with extension into the cortical veins and also the internal cerebral veins. And when you go looking at the sagittal T1, you can see there's already clotted blood within the internal cerebral veins, vein of Galen, straight sinus. This was a diffuse venous sinus thrombosis. The reason I wanted to compare it to this one is that this is also a diffuse venous sinus thrombosis. And as Mary was saying, MR and venous sinus thrombosis is a bit of a nightmare. Oh look, there's a nice normal flow void on the T2. There's no abnormal signal on the diffusion weighted imaging. Even the flare's got a nice normal flow void. But hang on a minute, he's had contrast. This is a child who had seizures following induction chemotherapy for ALL. And look, there's a big sausage of non-enhancement in the center of this sagittal sinus. Just be careful if you use spin echo as opposed to gradient echo. Just be aware that you can still see with post-contrast imaging some internal flow void with a post-contrast spin echo in T1, whereas if you're using a gradient echo sequence post-contrast like MP-RAGE, then that should be filled in. The susceptibility weighted imaging can help you here. You've got this abnormally thick and blooming artifact, again, from the clotted blood in the veins at the convexity. But again, if you're not sure, we use phase contrast in my institution for MR venography. It's not perfect, but at least you don't get the T1 shine through that you would get with time of flight. This is a particularly nice paper from ClinRad from last year, and it's got a really good review of the MR signal of blood and also incorporates the susceptibility and diffusion-weighted findings that maybe older texts or papers might not include. Just to finish off quickly, children do have strokes, and it does happen. But they tend not to be quite as obvious in their clinical presentation as adults. This is a 12-year-old who had sort of a day or two of headache. She kind of wasn't quite right, had some left-sided facial weakness. So it wasn't kind of immediately obvious what was going on, but CT head, again, just to reiterate, I'm sure you'll do this anyway, but to use stroke windows. So particularly in children's brains, everything's all packed in together. There's not much space to compare things to. This is a window width of just 16, so I've really kind of narrowed the windows there, centered around 35, and you can see the missing density of the basal ganglia there. Just in case you didn't believe me, that's the DWI. So this is a striatal perforator territory infarct, so we're going to be looking at an abnormality in the MCA potentially. And this was the MR angiogram, and the reason to kind of show you this is that a large proportion of children have arterial abnormalities as a cause for their stroke if it's not cardioembolic. And on this case, you can see that there's abnormal thinning, beading stenosis of the right MCA, and which 3 months later on follow-up had completely resolved. So again, here you can just see that it's now nice, smooth and fattened up again. So this is what's called transient cerebral arteriopathy. This is a sort of global collective term for any kind of abnormality that can transiently affect the vessels and cause paediatric strokes. That includes things like post-varicella vasculitis, even includes a cervical dissection or other kind of arterial dissections, and moya moya. So it's a very kind of global catch-all term, but the reason to kind of highlight it is that it's present as a cause in about 60% of non-cardioembolic stroke in one way or another. So vascular imaging is really important if you see stroke in children. So in summary, I think I've shown that from our graph at the beginning, infection is the commonest cause for doing paediatric neuroimaging. So if you're kind of confident on that, the patterns are pretty similar apart from the herpes simplexes in adults. So that's not too difficult. To improve your sensitivity in interpreting HIE, just know what you're looking for, really. If you know the patterns, in real life, like that case with the mixture of the diffusion signal change in the hippocampus, basal ganglion cortex, you sometimes get a mixture, so you're not going to be able to go, this was the amount of downtime there was definitively every time. But again, the patterns will help you pick up more sensitive findings. I would encourage you in under ones to increase the TE on your T2 if you don't do already. I really find that helps. The other thing in under ones is maybe you might want to reduce the B value on your diffusion weighted imaging as well, which helps reduce some of the T2 shine through from the brain being so wet. So we tend to use a B value of about 700 in the first 6 months of life. Venous sinus thrombosis will get you in the end, one way or another as a radiologist. So it's good to be aware of all of the different permutations. And I would encourage you to do vascular imaging in paediatric stroke because there's often abnormalities underlying the apparently normal stroke presentation. Thanks very much for your attention.